Good afternoon, everyone, and welcome to today's virtual Grand Rounds. I'm Dr. Kim Newell-Green, and as usual, I'll be the moderator today. Our Grand Rounds is entitled After the Public Health Emergency, Post-COVID Clinical Care. First, I just want to acknowledge CDPH, the California Department of Public Health, is our partner in providing super relevant public health education for the physicians and other healthcare practitioners of California. And I also want to remind everyone that with the health emergency ending in California on February 28th and nationally on May 11th, our series is now pivoting to address all public health topics that are relevant from California to California physicians, not just COVID-19. We've received lots of great feedback about how this series has helped you in your practices and in caring for your patients. And we hope that we'll continue to be able to do so by addressing a broader range of really up-to-the-minute public health topics that are relevant for clinical practice. Next slide, please. Here are our speakers' disclosures today. Next slide, please. And here is our agenda for the day. Next slide, please. And just a reminder that this series is accredited for CME credit. So you'll be sent a survey after the completion of the webinar where you can attest your attendance. And after this completion of the survey, we'll send your certificate. So today we are really happy to have two speakers, one of which you can't see because of technical difficulties, but she's here with us. And as I alluded to, since the public health emergency is officially over and May 1 marks the end of the federal public health emergency, many of us are wondering how will this impact our practice and the care of patients in California. So today we have Yingjia Huang, the Assistant Deputy Director of Healthcare Benefits and Eligibility at the California Department of Healthcare Services, and she will join our usual presenter, Dr. Erica Pan, who you see here with me, to update us both on the state of COVID-19 in California and give some other public health updates, and also to talk about how the end of emergency care changes care delivery in California and beyond. So Erica, take it away.
Great. Good afternoon, everyone. Thanks for having me again. Always a pleasure. Let's go ahead to the next slide. And let's do one more. So yeah, I'll give you kind of my usual, although much shorter, COVID epi update. A little bit about just some recent news about COVID-19 vaccine bivalent doses or boosters, and a little bit of more of the public health lens on the ending of the state of emergencies. And then just a brief couple updates on Marburg virus in Africa, just to keep you up to date. And then I'll be able to turn it over to Yingjia Huang to talk a little bit more about the Medi-Cal perspective on ending the public health emergencies. Next slide. So I think the bottom line as far as these numbers is they've been very stable for the last several weeks. We've had pretty decreasing or stable hospital admission rates. Test positivity has been ranging around 5%. It did tick up a little bit in the last week, so we'll see what will happen moving forward. And our effective is a little bit above 1. It's been, again, relatively stable for the last several weeks, as has our case rates from reported cases. As far as variants, the highest proportion right now is still this XBB 1.5, but we are seeing XBB 1.16 and FD2 are increasing. They're both still less than 5% total, I think, but starting to increase over time. And then next slide. Also, just going to highlight ED visits, and I'll explain why in a moment, but ED visits also seem to be decreasing over time, and then this is also just a 7-day admissions, new 7-day admissions graphic as well, and you can see we are at low levels. They've been, as I mentioned, really kind of quite stable for the last couple months at least, and you can see also that these are, you know, at sort of levels that have been either prior nators or similar to prior nators, so I do think this may be kind of our baseline right now as far as where we are. Next slide. And then as far as wastewater, we are seeing decreasing or plateauing at low levels with wastewater surveillance pretty much in all regions of the state. We continue to have less data from our rural northern parts of California, but everywhere else we're seeing, compared to 3 weeks ago, lower levels of SARS-CoV-2 in our wastewater. Next slide. So what is going to happen, as we move forward with the federal ending of the federal public health emergency and with COVID-19 surveillance in general? We are really going to be shifting away, and already have in many ways, from case-based reporting. And certainly there are very few individual case investigations at this point, as it is, but we have been reporting, as I just did, the reportable cases to us. But instead, I think the shifts that we're going to see are a focus on other key trends, which is ED visits, hospitalizations, deaths, and in California specifically, we will still be following test positivity because we still have a requirement that all labs continue to report both negative and positive testing. That particular element is not happening in every state, so test positivity nationally will not be obtainable. So as we focus on these following key trends, currently we get our ED visit data and our hospitalization data as far as those kind of more timely trends from hospital surveys specifically, and a lot of that data will continue to be required in the NHSN, the National Hospital Safety Network, but there will be some transitions in how we're collecting that data over the next several weeks as the end of the federal public health emergency ends. But we do hope and think that that will be consistent as far as what we've been receiving already. Over time, we're also going to be looking at syndromic surveillance from emergency rooms, but we actually don't have statewide as much access to that, and it's still only representative as far as a national network of probably less than a third of the EDs in California. So we're really hoping to continue getting this data from the National Health and Safety Network for ED visits and hospitalizations. Deaths will also be defined slightly differently, really focusing on those numbers a little bit more like what we do with flu, which is focusing on death certificates rather than getting the full investigation and report from local health departments on their cases and which ones of those have died. Over time, over the next several months, and certainly as we look towards the winter, we want to use so much of the lessons we've learned over the course of this pandemic to improve our overall respiratory surveillance and continue to integrate kind of COVID-19 into our other flu and RSV surveillance, but also improve those other surveillances with some of the things we've gained through the pandemic. So with the CDC, the COVID-19 community levels that you have seen are likely ending. I think there are likely still going to be some focus on hospital data at the national level as well. And then the community transmission levels that have really guided some of the guidance in the healthcare setting specifically also are going to end because, as I mentioned, there will not be a test positivity available nationally after the end of the federal public health emergency. Next slide. There will still be other enhanced COVID-19 surveillance. We want to, not quite in this order, actually in backwards order from this, we will continue what we can with wastewater surveillance. We may not be able to expand the way we had hoped because of budgetary sort of constraints, but we'll be able to summarize data that we're getting from various wastewater plants and their various sources that are providing that data and synthesizing that and providing that on our dashboards. We'll continue to do whole genome sequencing and variant surveillance and continue to have that data on what we call our Nowcast. And then that is also on CalCat, and there's a link on this slide. And of course, if you just Google CalCat, you'll see, hopefully many of you looked before, you'll see not only our COVID-19 data and projections, but now we have flu up there as well. And then this is a snapshot of what that integrated projection looks like. And as you can see here, it looks again like it's going to be, it's been stable and is projected to stay stable at current levels. But we're going to maintain all of those things certainly through the next winter season. Next slide. And then I wanted to shift gears and talk a little bit about what's just recently released from CDC and FDA related to COVID-19 vaccines. Over the last couple of weeks, the updates are that all doses administered to individuals will be the bivalent doses now. So the monovalent vaccines are no longer authorized or recommended for use. So they basically, again, not authorized, and people should be kind of pulling them off the shelves. So essentially all doses moving forward for 6 months of age and older should be the bivalent formulations of the mRNA COVID-19 vaccines. For everyone 6 years of age and older, one bivalent dose, regardless of the number of prior doses, including if you had not previously gotten a dose, if you've gotten that, you'll be considered up to date until there's any future formulations and or booster recommendations. There's a meeting coming up in June with ACIP where I think they're going to talk about whether this will be an annual recommendation or and have some more discussion about that. It's still a little bit confusing for the 6-month to 5-year-old range. There's still 2 to 3 doses recommended depending on the manufacturer. So I think for Pfizer it's 3 and Moderna it's 2. And then also recently, both FDA and then ACIP endorsed and CDC endorsed that anyone 65 years of age and older or any other medical conditions or immunocompromised may get, it was sort of a liberal, not must, but should or may consider getting another booster dose so long as it's been at least 4 months since their last dose of getting that bivalent dose. No other changes to the Novavax recommendations or J&J. Next slide. So, I think some of these steps are both to have the best sort of vaccine that covers at least a couple different variants and also just simplify the recommendations. And as I mentioned, there'll be an upcoming meeting in June that might bring other updates as well. Also really important for you all to know as clinicians and as your patients are asking you questions, deauthorization of the monovalent product was not related to any safety concerns. It really, again, was just optimizing the vaccine doses that we are going to continue to give to have that bivalent coverage. And it was based on a review of all of the data, including effectiveness, safety, really looking at population immunity is what influenced that decision around, even if you've not ever received prior doses, 1 bivalent dose you'll be considered up to date. And then implementation considerations, which are always important as well, as you all know, because you're the ones implementing these with your patients. So it'll be simpler, single booster for most persons. Some flexibility though for those who are at higher risk. And then, as I mentioned, it's a little bit more confusing for younger children now too, and we'll stay tuned and see as data evolves if that will change as well or not. Next slide. So shifting to other impacts of the ending of these various emergencies, this is a really helpful slide that one of our team put together. I may have shown you a version of this last time as well, but as Kim mentioned, at the end of February was when the California state of emergency ended, and then May 11th is when the federal public health emergency ends. And May 31st, and Ying Jia will talk much more about Department of Healthcare Services insurance, but certain uninsured program ends then. And then the June 30th timeline on here is really important for us at the state as far as our fiscal year, and as we're demobilizing a lot of our COVID-19 response, that is the end date for some of the things that we have provided resources for. And on that note, I can just speak at this moment about a lot of the resources on the ground as far as, community testing sites, being able to have outbreak response teams on the ready to go into outbreaks and contact tracers. All of those things are winding down. Many of them have already wound down or will end by the end of June. We are still doing our test to treat certainly through the end of June and still looking at what that will look like moving forward. And then, what we're hearing is May through the fall is when there will be commercialization of these various resources. And then I am going to let Ying Jia talk more about the different timelines related to cost sharing and out of network, et cetera. The one other thing actually I'll mention here on this slide is October 1st is when the PrEP Act coverage ends as far as provider immunity for providing some of these clinical care and resources. Next slide. So from a public health perspective, I likely already know, but just to reiterate some of the things that we've rescinded already as we wound down the California state of emergency. We, effective as of April 3rd, the vaccine mandates from the state level are no longer a requirement for healthcare workers, adult and senior care and direct care workers, and corrections facilities. This allows the local facilities to do what they often do and have other vaccine requirements for their facilities. The hospital healthcare surge order went away, and that was really about level loading. If we had really big surges, especially for ICU capacity, it allowed us to really work with regions to level load, and that has no longer been needed. Thankfully, we haven't needed that order since the really severe prior winter surges. Care reporting had been an order and has now actually been put into legislation that all vaccines actually are required to be reported. Next slide. And then we did some recent changes as well, a minor change, but with isolation, saying that infected persons may leave isolation after day 5 if they have no symptoms. This is previously what we had said, but we had a caveat around testing. You have to have a test negative to come sort of back to work or things like that after day 5. We aligned with what the CDC had already said without emphasizing that. You do, however, our recommendation is still to be wearing a mask for 10 days unless you've tested negative twice. So that was effective actually in mid-March. And then as of April 3rd, we removed the masking requirements in healthcare settings and other high-risk settings, such as SNFs and other places. And they previously had been guided by those COVID-19 community levels. But this, again, allows some flexibility at the local level and healthcare facility levels to have the flexibility within your institution and your facility on where your highest risk settings are. Next slide. And then this is a very busy slide, but hopefully just a good resource for you as you can, download these slides for the future. But our team put together this kind of categorical vaccines, treatment, and testing, and what the different impacts are on Medi-Cal fee-for-service, Medi-Cal managed care, Medicare, and then of course commercial plans and uninsured. I think I won't read through the entire thing, but I think some of the themes are that vaccine specifically coverage will continue for all of the different insurers, and then even for the uninsured, even when the California Healthcare Service uninsured program ends, there are some other ways that we are hoping for our sort of safety net that uninsured children should still be able to get COVID-19 vaccines through the Vaccines for Children program. The federal government just announced in the last week or so the HHS Bridge Access Program, which is aiming to expand vaccines for adults, which is how we actually get some flu vaccine to some of the underinsured high-risk adults as well. And also they're providing some via pharmacy partnership. And then of course, as always, sometimes people who are underinsured can get other care or coverage through some of the community clinics and things. For therapeutics, coverage, depending on your type of insurance, varies a little bit. And then out-of-network coverage ends after November 11th for example, Medi-Cal managed care, both for therapeutics and testing. One important thing to highlight is that the 8 over-the-counter tests that insurers need to cover per month for members will actually continue in California because of SB 510. So I think that's kind of the highlights. And again, you can have this slide as a resource, which has been really helpful for all of us too, as we try to understand the nuances of all these changes. Next slide. So I'm going to shift gears just to give you a couple quick overview of Marburg virus. So this is a filovirus, which is part of the Ebola virus family. It's another hemorrhagic fever virus. It's very rare, but it has an extremely high fatality rate. It does affect people and non-human primates, and it can cause outbreaks, again, with really high fatality rates. So the symptoms and mode of transmission are very similar to Ebola virus. And unfortunately, unlike Ebola virus, there's no vaccine and there's no current treatment for it as well, other than supportive care. So that's why it's concerning, once one does contract the disease. Next slide. So there have been outbreaks in both Tanzania and Equatorial Guinea. So both West Africa and East Africa, these are the first reported outbreaks of these in either country. And there is no, currently, as far as World Health Organization and CDC understand, no link between these two outbreaks. And you can see basically 8 cases confirmed in Tanzania and at least 17 cases in Equatorial Guinea with really high case fatality ratios. 63 to 71% of those cases have died. There may be some undetected community transmission in Equatorial Guinea. So far, Tanzania has remained quiet since those additional cases. Next slide. So we have sent out KHANs about this, California Health Alert Networks. The CDC has also sent some health advisories around. We are not, and the CDC is not recommending monitoring or screening any travelers that are coming into the United States or California from these countries, but the CDC did start sending these automated text messages for travelers they knew that were coming back from these countries, just to make sure they're aware of the disease and the symptoms and to seek care from their local and consultation from their local health department and local care if they do develop any symptoms. We still think that the risk of global spread and introduction into the US is extremely low, but again, it's a high fatality disease, so we want to be very vigilant. It's been a pretty low number of travelers who have come in just under 200, 170 travelers into California. Most of those have been US citizens who are returning travelers. So it's just a reminder always that you should be always asking patients with signs or symptoms of infections, especially fevers or other infections about any recent international travel. And then if there is any concern at all for this disease, immediately call your local health department, take infection control precautions, and then the local health department can start to walk you through it. If it is high suspicion based on where they were in those countries, they will start to involve us and the CDC, and we will all get on a call together to walk through what's next, including any potential testing. And we do have capability in California at a few different facilities to do Marburg virus testing. Next slide. So with that, I will close and just thank all of you. I think this is just to symbolize, we're out of not only the winter storms, but feeling like from a public health perspective too, we're kind of emerging from this very, very long public health emergency and trying to, reset and renew and recover, and also continue to build on the lessons learned and resources we've gained during this pandemic. So thank you all, and I'll turn it over to Ying-Jia.
Thank you so much, Erica, as always, for that really complete summary of what's going on and the changes that are happening. I'm going to invite Ying-Jia on. I'm guessing that the camera is not working, but she's here with us verbally. So just to introduce her, Ying-Jia Huang is as I said before, the Assistant Deputy Director of Healthcare Benefits and Eligibility at the California Department of Healthcare Services, where she oversees the development and implementation of both benefit and eligibility policy for the Medi-Cal program. In response to the COVID-19 public health emergency, Ms. Huang co-directed MCED's efforts on all of the eligibility flexibilities, policy rollout, and implementation, and we're so glad to have her here today to tell us what's happening in Medicaid, California's Medi-Cal, at this time, at the end of the public health emergency. Thanks, Ying-Jia.
Hi, everyone. Good afternoon. My apologies for not getting my technology working, but wanting to share from Department of Healthcare Services, which oversees the Medi-Cal program in California, some of the big initiatives, and I'll kind of talk through them. I think Dr. Pan also shared kind of two pieces that I could also touch on towards the end of my presentation. But today, definitely wanting to highlight the first item, and that's specific to continuous coverage. Next slide. One more slide, thank you. So for many of you who may be aware and probably are seeing a lot of messaging around Medi-Cal redeterminations, that it's about to begin. We are in the media quite frequently now with various outlets pitching the kind of the moment. So as background, when the COVID-19 public health emergency began in March of 2020, federal requirements and also California's own public health emergency paused all adverse actions, and specifically that annual requirement for our Medicaid members in the state to redetermine or have an annual redetermination done. So Medi-Cal, every year, all our members, and we do it by households, like as a family, where they actually have to go and redetermine their eligibility, and it's done through, it's a no wrong door path. They could go to their local Medi-Cal County offices. They could do their renewal online, on the phone. There's various methods, but in March of 2020, when the public health emergency began, all that ended or paused. And so as the years since 2020, DHCS has been preparing for this moment. And just for context, as of March of 2020, we carry 15.7 million Medi-Cal lives in the state of California. And that is the largest and the biggest volume of individuals from a program caseload perspective in the nation. So what's going to happen is once what we call the unwinding begins, once the public health emergency ends, we have a huge task ahead of us. So in the last couple of years, as we are preparing, it's very difficult to prepare when the dates for the federal public health emergency keeps shifting. So it's really tied to that federal date. So in December of 22, when the omnibus was passed, what happened at that time, due to the advocacy of many state Medicaid programs, is this protection or this continuous coverage of individuals that we keep in coverage throughout the pandemic. We call that the continuous coverage requirement, was delinked from the COVID-19 public health emergency. So in essence, those two dates are now separate, and that continuous coverage requirement will end March 31st of this year, meaning that the redeterminations process that has now been paused for 3 years will now begin. So in preparing for this moment, Department of Healthcare Services released kind of our blueprint, or what we call the unwinding plan, that's on our website, which kind of speaks to all the areas that we had to queue up in terms of operational readiness. Next slide. And what this actually means operationally, every single Medi-Cal household will be redetermined with this policy. We anticipate, because we have not recertified your eligibility in the last 3 years, and that looks at income and changes in your family household, change of jobs, for example. We do anticipate that, just from a projection perspective, 2 to 3 million individuals currently on the Medi-Cal program may potentially be disenrolled, primarily due to procedural terminations, meaning we cannot deliver the redetermination packet to them because they have a change of address, or their income has changed or increased, whereby they will then now, instead of being qualified for Medi-Cal, they will move into the state-based exchange, which is Cover California. Some of them probably have gained employer-sponsored coverage in the last 3 years. As well, and because of this federal requirement to protect them in the Medi-Cal program, we cannot disenroll them. So as the redeterminations begin, and it began April 1st, so that date was finally here, we will have to redetermine them. And that process in the state of California will take 14 months. It begins April 1st. It will end on May 31st of 2024. And the strategy in which we're doing it, just because it's such a huge volume of people, we had to be very deliberate in our approach. We will spread out all the redeterminations to not hit everybody at the same time. It will be based upon the household's redetermination month. And most times it aligns with the month in which they probably applied. So keep in mind, a lot of these individuals probably, so at the eve of the pandemic, Medi-Cal's caseload was about 12.8 million. Grew to 3 million more. And so there are a lot of individuals that came onto the program when no redeterminations or that requirement was needed. They're not used to getting a packet from their local county office asking them to fill out information and kind of knowing to return that to continue their coverage. And secondarily, we know from the department that many of our Medi-Cal members have moved, because we did send out a mass mailer late 2021. We got about almost 2 million returns on undeliverables. So we know our members have moved throughout the pandemic, and it's very critical for us to find them so that we can actually deliver the packets to them correctly and help them through the process. So as I shared, April 1st was the date which redeterminations began. Because we always start the redeterminations by policy about 85 days prior to the due date, it is starting April 1st and is actually for the first group of individuals that are due, have their renewals due on June 30th of 2023. Meaning that packets are already out the door. It should be reaching the doors of our Medi-Cal members' households, and they will need to return their redetermination packets to the counties by the deadline, which is June 30th. And not every family will get a packet. There will be individuals who the counties can auto-renew based upon federal databases and the information. So those are the people we call auto-renewals, and meaning the counties will then just send out a notice saying, hey, you've been renewed for 1 year. But there will be a large portion of individuals, I would say 70%, will probably be getting a renewal packet that's pre-populated in their preferred language, sent out in a yellow envelope to them to fill out the information. So we anticipate the first dip in the Medi-Cal caseload effective July 1st. just given that June month of renewals, and then we're probably going to be taking that adverse action on the member at that time if they did not return their packet, basically not completing the requirement for the redeterminations. They will be moving off the program July 1st. Next slide, please. So what outreach have we done for, not only to raise awareness to our members, but also to the community, and that includes you as well as providers. So since April of 2022, we have kind of pitched this concept of the DHCS coverage ambassadors. Next slide, please. Where the coverage ambassadors is a network of trusted messengers in the community. So you have lots of community-based organizations, local clinics, FQHCs, providers, managed care plans, state agencies, local Medi-Cal county offices, consumer advocacy firms, groups who have signed up. And this is like a service where we sign you up and then we develop varied these communication toolkits, if you will. And now it's translated in all 19 Medi-Cal threshold languages, and the trusted messengers, which is our coverage ambassadors, will take them and they would disseminate it out to the Medi-Cal members that they interact with more on the ground. And we have done significant focus group testing, kind of talking to a lot of our members in terms of how they perceive this information and have really tailored it so that it makes sense to them. And currently in April, we have about 1,700 plus organizations that have signed up with DHCS, and obviously encouraging all of you to also sign up to get the information so that, we could definitely, share and use your help in that spreading of the message. Within these toolkits, we have a bunch of collateral materials, with the new DHCS logos and things like that, where it really is a one-stop to whether it be call scripts, FAQs, flyers, things you can put on your website, graphics, things you can use for social media as well. You could just take and shift and then repost, for example, or print out or customize for your use. Specifically, as part of this effort, we are also creating a provider-specific toolkit to push out to our providers, given that your interaction with our members are probably more frequent than, say, a state agency. And that's also something we have heard through a lot of focus group testing as well. And also, we created DHCS a one-stop shop because we know Medi-Cal is very complex. It's not easy in terms of how do I apply, who do I call? So we created a one-stop shop on this domain, keepmedicalcoverage.org. And for the first time, the department will be doing actual emails and text messaging. Previously, it was done through the local county offices, but we believe that that outreach is such a significant part, a pillar of our success here, that we really need to stress. And we need to promote that awareness because we know our members have moved and that they don't understand that with this redeterminations piece of their coverage is coming back. And if they don't take action now, there may be adverse consequences for them and their family. And that was very apparent as we were doing our focus groups so that we're enhancing our communications so that we're kind of hitting the message correctly. So all these toolkits within it will have these FAQs that will be very helpful, I think, for providers as well, just the general ones. And then we will also have a very tailored outreach toolkit for you as you interact with your patients that do come in and as you swipe their cards for eligibility and they are a Medi-Cal member. Check in with them. Hey, have you updated your contact information with your local county office? And if they say no, you can direct them to keepmedicalcoverage.org to give their county a call or log into their online portals that has their all the information on their Medi-Cal, and then to update their information just so that we are kind of minimizing any continuity issues when their redeterminations come up. Next slide, please. And here's just some examples of the messaging we have created and that you probably are seeing in different places. We have partnered with lots of pharmacies, large retail chains, grocery stores, and then YouTube, Spotify, Hulu, lots of where we think the interactions are with our beneficiaries to really meet them in their everyday life. And so all the materials I'm sharing with you here are actually enclosed as part of the toolkit. These are the messaging that we've tested with them, and they're like, yeah, this makes sense. I understand now that I have to take certain actions. And so throughout the toolkits, as you are, taking a look at them, if you do have a Medi-Cal member that comes to see you on, that this is the message we provide to them as like just to make sure it's very consistent with what we deliver to them. Next slide. Yeah, and these are some of the samples. We have actually put them up in a lot of public transit areas and bought various domains so that if they're searching for on Google, for example, how to keep Medi-Cal, our Medi-Cal, keepmedicalcoverage.org pops up just so that they know they're clicking on the right information. Please. And we're also partnering, just really kind of celebrating the differences that we have of the demographics that we have in our program that we serve. We made sure we are partnering with local radio stations. And again, just really acknowledging Medi-Cal has 19 threshold languages, so making sure we're reaching those communities and that they do understand that in order to keep their Medi-Cal, that there is certain actions they need to take. But we don't want to cause agitation, but just to gain that level of awareness, that broad awareness that a requirement is coming back and certain actions are needed. Next slide, please. Yeah, these are the flyers that is made available to you as well on our website for you to share in your offices with your partners and colleagues. As well. And these are the same consistent messaging we deliver. The counties actually take this and they also share it with the applicants or members that do come into their office for assistance. And I'm going to close out that piece. And Kim, back to you.
Great, thank you so much. So lots going on in California right now, and we have lots of questions about it. So we'll invite Erica back on to answer questions, and also Yingxia is here for these. So Erica, just to go back to the COVID questions or the COVID stuff that you were going over at the very beginning, there was a question specifically about the new variants of clinical significance and whether there's anything that we should know about difference in those variants. I did, someone had read something and I read it myself about maybe presenting a new variant presenting with more conjunctivitis, for example, and our school was getting worried. So was there anything we should know about these new variants particularly?
Yeah, have seen some of the anecdotal and media coverage on that. It is really just anecdotal at this point. There isn't a lot of data yet on that. I think the other thing of note, I didn't today present as much about respiratory virus surveillance in general, but adenovirus is also on the increase, which also causes a lot of conjunctivitis. But there do seem to be several anecdotal reports of this, but again, nothing that we've seen that's really comprehensive about it. The mutations, do look immune evasive as well, again, but besides this anecdotal of conjunctivitis, certainly nothing signaling more severity as far as hospitalization. So I think more data needs to be collected on those.
Okay, great, thanks. A lot of people are sort of trying to figure out what are the meaningful differences for patients in California that are going to happen between kind of now and November 11th. And I think that probably is, if I understand that whole arc of all the changes, the meaningful things are going to happen based on how the commercial plans change some of their policies and coverage in November. What's your sense of that? How would you answer that question? Knowing what you know now, or can we yet until November happens? Is
that a question for me or for Yingxia?
Either of you. I mean, Yingxia, from the point of view of Medi-Cal, it feels like those changes, are there changes that patients are going to feel between now and November that's going to be differ? And then Erica, do you have any sense of what might change in November, other than we'll have to talk with the commercial health plans, which in fact, we're talking about doing a thing on this series just to sort of have some representatives of the health plans across the plate, across the state, to just help us understand how they're viewing the changes, but that will come closer to November. But anything that either of you can anticipate that might look different for patients now versus November.
I mean, I think sort of independent of the health plans, I think, it's been a little bit easier to, get some of these resources that the government and or the state has provided in the community. So a lot of that is definitely winding down, but I don't, I think that really to me is one of the bigger changes. But many people were already starting more and more to access these resources from their own kind of traditional healthcare system. So yeah, I'm curious too, kind of how the commercial health plans are going to approach this, but I don't have much more information either.
Okay. And Yingzha, in terms of the changes in Medicaid, just because there was a lot of information in those slides, aside from the eligibility stuff, how will Medi-Cal folks covered by Medi-Cal feel the end of the public health emergency, do you think?
I think the ending of the COVID-19 PHE probably not, it won't be as apparent, I think, to the patient. I think we're like from a telehealth perspective, which is a lot of that, for those flexibilities were tied to the PHE. We're continuing a majority of the telehealth pieces with the ending in May, and for the eligibility part, just knowing that the predetermination policies are coming back, and that is really probably the biggest hit in terms of that visibility. But broadly, all the policies tied to the PHE, most of them are continuing from the perspective.
Okay, great. Thank you for bringing up the telehealth question. I think a lot of folks have asked us, will telehealth visits still be allowed in California? Will the reimbursement for those visits change? And will different insurance plans have different policies around this? And so we heard Yingzha about that. There is, I'll just let everyone know, a pretty concise and helpful resource from the CMA on some of the changes that are going to happen, including a paragraph on telehealth. And at the end of this webinar, after the webinar, we'll send you that link. It's available for CMA members, so that's a great resource. And the good news is that CMA has sponsored a number of bills. I'm just looking at this resource starting in 2019 and 2021, several bills which will require folks, commercial payer contracts, and all commercial contracts will have some telehealth parity with in-person visits. So you can get more information on that thing. We may, if there's enough interest, have sort of more discussion on how telehealth evolves, because I know that's become a big part of our world. So I'll just say that. Erica, anything to add there from your perspective? No. Okay. What about, Erica, are there any changes that you anticipate happening with the school policy recommendations? I know that last summer before this school year, there was a big policy update. Is there a plan to kind of re-update that to look towards the 2023-24 school year?
Yeah, actually, I'm excited to kind of foreshadow that what we have an amazing team working on is a really user-friendly school guide for infectious diseases in schools in general that is more comprehensive, and some, it's trying to pull from some of the things in the Red Book, for those of you who are pediatricians and use that as a Bible, and the Caring for Our Children that AP puts out as well, and just other kind of input from other practitioners and local health departments. So that is actually what we're shifting to and working on. We're getting some broad input on it now, but really thinking about not only COVID-19 or other respiratory viruses, but kind of just a little bit of a primer, trying to make it as school and user-friendly as possible. So that's actually what we're shifting to. And I forget what our timeline is looking like, but that's what we're working on. So yeah, that could be another fun topic in the future as we roll that out.
Amazing. Yeah, I think we should definitely do that. And just timeline wise, so that everyone here can anticipate, do you imagine that it will happen before the next school year, or that may linger a little longer?
Yes, I think so. Yeah.
Great. Good. Thank you for that. A lot of folks are also asking about masking and sort of what the question from several people was, what makes smart sense? What makes sense now in a clinical setting as folks are developing and evolving their own policies, whether it be at a smaller office or a larger office, as we think about viral management going forward. Any thoughts on that?
Yeah, sure. And we do have a few principles, admittedly, they're a little kind of buried in our Q&A about when we updated our masking, and happy to send out that link after as well. But I think, like many other things, I think it's kind of, yeah, using some key principles. So I think if the question is about healthcare setting, I certainly for any patient that has respiratory symptoms or a fever, it makes sense for you as a provider to not only mask the patient, but mask yourself. And at this point, I would recommend an N95 respirator, because it could be COVID or some other airborne disease, even though I think traditionally often most clinicians pre-pandemic probably just put on a surgical mask. I would say wear a respirator. I think they're hearing about different, and admittedly, this is a little bit more anecdotally. I think, there are some facilities that are still, certainly in like a cancer clinic or an immunosuppressed clinic, I would say you would probably want to have everyone continue to universally mask in that setting. You just have a really vulnerable population. If it's a busy outpatient clinic with others healthy, you might want to do it that a little bit more symptoms-based. And then some facilities are having different rules or guidelines around sort of patient care areas versus just staff, break rooms and other things like that. So I think a lot depends on your patient population, you as a provider even too. If you're an elderly provider, I'm increasingly getting closer to that age too, but you might want to just wear your respirator all the time, like while you're taking care of patients, depending on the ventilation and the air exchange in your clinic. And then of course, looking at levels of transmission, which, I kind of alluded to how we'll continue to try to keep our eyes on that pulse. Certainly if levels of transmission get higher, you might have a lower threshold to wear a mask. I mean, that being said, outside of the setting, I'm still personally on public transportation. I'm still going to just wear a mask, I think. But otherwise, I'm actually not wearing a mask in most places now. So, but then I'm doing other things like, if I'm seeing any ticks in disease, I'll probably still test our family before we have an indoor meal with my parents. So I think there's still a lot of different tools we can use in different times, and masks are one of them. I do think while I'm on this topic and we're working on some materials to really emphasize this even further, I think clinicians know this, but just to reiterate, if you're masking to protect from COVID, you really want a well-filtered, well-fitted mask. And really the gold standard is still the N95 respirator. There's a lot of discussion too about with the KN95s and KN94s, which admittedly I find easier to use and implement. When you have the ear straps as opposed to the over the back of the hair, they often just don't fit as well and have as tight of a seal. So if you are really concerned, you really want to emphasize having a well-filtered, well-fit mask, and N95s are still the gold standard as far as the best regulated, industry standard.
Mm-hmm. And what about other risky settings? So, do you imagine that there will be use of that organizations will have mask policies for crowded spaces or events or things like that? Or certainly from the public health side, is there any recommendation, soft or hard, about that?
Yeah, I think our, I forget what we're calling our guide, but our special events guide can still be applicable. I think, again, thankfully, we are currently and recently at pretty low levels, but if and when levels increase again, I think there are some guidelines there too, whether it's indoor versus outdoor, how crowded, how it's ventilation, to help guide some of those decisions.
Mm-hmm. Great. Other folks were asking about some other elements of practice operations like cleaning and sort of disinfection guidelines for various healthcare settings, and have those changed? Are they comprehensive guidelines anywhere that you publish that says, here's what you should do in inpatient setting or an acute setting, care setting, or treatment rooms, those kinds of things?
The cleaning recommendations have really not changed over the last couple of years even. I think, you want to use other standard procedures that you do for cleaning between patient rooms and other things. And that's certainly not just for COVID, but for some of the other hardier viruses in the environment like noro and other things. So, but standard, I think, standard cleaning precautions, and certainly having attending to high touch surfaces, doorknobs and other places is always a good practice, especially in the busier kind of viral seasons. But there's no real COVID specific changes in any guidelines about cleaning.
Okay. Yingxia, I'd love to ask just a really practical question of you, and that was such a beefy amount of information you gave us about redetermination, but just practically, say a patient comes into my office and we find out that they have lost their Medi-Cal coverage and think that this was about an address change and not actual, maybe we continue to believe they're eligible. How long does that process take to reassess eligibility if someone has been dropped for the roles, is unaware of it, and then applies again?
The counties have 45 days to reassess from a reapplication perspective. And the counties, if you did get disenrolled, if it's because you're in the redeterminations process, you have actually 90 days after your disenrollment date, which is usually the last day of the calendar month, to give the county a call and just share or provide whatever that information is lacking, and the counties will immediately put you back on a really quick reinstatement. That could be really quick if it's something as simple as disenrolling you because it was an incorrect address. So usually I would advise that if a patient comes to you and they're like, hey, I may have been disenrolled, if it's within 90 days, they should just give the county a quick call. The county should be able to reinstate them that day with an effective activation of their Medi-Cal the next morning.
Okay. And is coverage retrospective? In other words, if someone's in my office today is not covered, quickly gets that reinstated, but will my visit today be covered?
Yes, if it's within that 90 days, that's correct. It will be reinstated back to the date of disenrollment.
Got it. Okay, super helpful. Erica, you did a nice job of talking about how the state's able to continue surveillance efforts, not quite at the same level, but hopefully still keep an eye on what's going on. What implications does the end of the emergency have for some of the infrastructure that was built up, like testing sites and lab capacity? How does that sort of the level now compare to what it did sort of pre-pandemic?
Compared to pre-pandemic, that's an interesting question. Certainly compared to the peak of pandemic, we are dramatically decreased all of the resources. We have we still have some federal COVID funding from the CDC that's COVID specific through the next kind of our state fiscal years through June of 2024, and some ongoing state funding, although dramatically decreasing. I will just acknowledge that after that, we are really concerned actually that we are losing a lot of funding resources at both levels. So that is what we are anxiously awaiting, and also knowing that things are kind of uncertain with the economy as well, which impacts us for sure as well. So so we have a lot of resources through the next kind of fiscal year, and then I think we're really going to be advocating. So yeah, would appreciate other advocates as well, that we really do want to build on a lot of the great infrastructure we've built up and improvements we've made, especially because public health was so under-resourced as a start pre-pandemic. I guess that's, since you did ask pre-pandemic, I mean, we don't have comprehensive flu surveillance. We have sentinel surveillance, and we have some, very urban focused sentinel surveillance for flu and other respiratory viruses, but we really want to improve that and integrate it. Our hospital surveillance has certainly improved, and wanting to build upon that. So those are things that we do have more infrastructure for now, for sure. I think the other great resource we've built up that we are continuing to maintain is, from a public health investigation standpoint, we stood up what we call CalConnect, and really helps with contact investigation, case management, outbreak management, because what we had statewide before was really good for surveillance, just getting the data for just like kind of one-time cases, but not for more investigation or case management. So that's a great resource we've built up that will continue to, we've added Mpox to it, and we really hope to continue to slowly add other communicable diseases of relevance to that system.
Great. Yeah, that was, you sort of dived right into my next question, which was sort of as you look at our public health system in our state and in our nation, sort of the question was going to be what has changed, and you alluded to all of that. So maybe you can pivot that to thinking about what's happened at a national level, and are there communication structures or IT infrastructure or policies and procedures that facilitate more communication at a national level between this state and the CDC and from other states that you think will continue? Or, I mean, I think most people I've read sort of have the sense that it hasn't gotten as good as it needs to be, but are we better than we were before the pandemic?
Yeah, I would echo that we are better than before the pandemic. It is, we started so behind. I mean, just to remind people, and actually I have I can still see in my head, stacks of papers of lab tests faxed to the local health department where I worked, and then also we were doing all of our contact investigation with stacks of paper, right? Like we are really under-resourced and behind in public health when it comes to IT and data systems. And so there are a lot of efforts both in California and definitely nationally to improve. You know, there's this new bill around data exchange framework. I think really where, for me, from a public health perspective, we'll make a lot more progress that is going to take a lot of time and resources is electronic health record and health information exchanges to better coordinate those. I think nationally, the CDC is going through a big reorganization as well. And as far as data and technology, there have been some data modernization initiatives and funding, but it is, as we all know, expensive. Those of you who've been through that transition from paper medical records to electronic, it's a big investment of money, staff, resources, and time. And so those investments need to continue to be made. Again, yeah, we're certainly further along than we were, but I think we, you know, we're still, from my perspective, really behind a lot of, you know, private sector technology, and we're better at doing kind of dashboards and things like that too. But we still need a lot more public health workforce with those informatics skills and workforce. Just to, while I'm on the soapbox about all this, I mean, we have a really, like with healthcare directly, but also public health, our workforce is really, really tired and burnt out, and specifically in public health, I think. Yeah, we have a lot of these, and this has happened with every emergency I've been involved with, everything from, you know, post, you know, anthrax and smallpox vaccination, the early days of planning for pandemic flus, and then dealing with Zika and Ebola. We get these one-time categorical funds, and then they go away. And to maintain and invest in our workforce, we need more long-term sustainable funding. So I do hope people kind of continue to learn more and invest more in that and in these IT infrastructures.
Good. Well, I think we'll end on that, because that was a powerful voice of advocacy. And, you know, it's important for all of us as physicians, as part of in our local communities and at our state, to do the kind of advocacy that changes things so that we deliver care individually and at a community level. And we're so grateful to both of you for the work that you're doing in that regard to make Californians and national folks safer. So I really thank you both for presenting today's content, and thanks everyone who's listening in. Just a reminder, you will get that survey at 5 o'clock today, and you can attest to your attendance. And after you complete it, you'll get your CME certificates within a week. And we'll also have instructions on how to access the recording of this webinar. The slides are also available on our website. And so please do take advantage of those, because there's a lot of beefy information as we're making that transition. covidroundca.org. Our next, because we sort of postponed this one from our usual schedule, our next speaker series is coming up on Tuesday, May 9th, and it's going to be about long COVID and then neurological and psychological implications of it. So we have two great speakers coming, so please join us for that. And thank you, everyone.
Thank you. Great to see you.
Thank you.